Hello. Hello. Hello.
Hello, sir.
Can you see the screen? Can you see the screen?
Yes, sir.
Hello, sir. Good afternoon.
No, I know. Can you see
Yes,
the
sir. We
screen?
can
Yeah,
see
yeah.
the screen, sir.
Sorry. Okay. Now we'll start then. Got a little late. Sorry for that because couldn't get connect with you with the screen. Right. So today we're going to discuss about ovarian tumors. Right. Okay. And so ovarian tumors are tumors which arise in the ovaries. You have two ovaries, left and the right ovary. And so you should have a little knowledge about the embryology of the ovary, development of the ovary, plus the function of the ovary. Ovary functions by secreting hormones. What are the functions of the ovary? Secrete hormones, especially estrogen and progestogens, and is being under the control of the central nervous system with the pituitary and the hypothalamus. So you should know something about physiology. You have done this uh, physiology of the reproductive system, where the ovary is under the control of the pituitary hormones, follicular stimulating hormone and luteinizing hormones. Right. So having that in mind, so the ovarian tumors are divided into four broad categories. One is functional tumors. By definition, functional tumors are physiological tumors, which happens during in the ovaries during during the menstrual cycle. You know there are certain changes which happens in the ovary due to follicular stimulating hormone (FSH). There are many follicles being formed during the first half of the menstrual cycle, which we call the proliferative phase, and during which time one follicle dominate, and with the influence of the luteinizing hormone, that follicle now starts ovulating. So ovulating, and then during this physiological process, one of the follicles can remain as a cyst, and then these are called functional cysts. Sometimes during pregnancy, due to high secretions of beta HCG, human chorionic gonadotropins, sometimes the ovaries can become more cystic, and then it's called the physiological cyst. So the physiological cysts are by definition are formed during the normal function of the ovary due to the influence of the hormones. Then there are inflammatory cysts due to inflammation. Inflammation is due to those are inflammation you get it from the external due to infections. Now, after childbirth, you can have infection, which is called puerperal sepsis. Then, after an abortion, you can have an infection. So, these are called pelvic inflammatory diseases. Inflammatory. And then, these inflammatory diseases can cause cystic structures. We call them tubo-ovarian masses. Tubo-ovarian masses, and these are due to inflammation of the both ovaries and the tubes. Then there are cysts which are called metaplastic cysts. Metaplastic cysts are now cells in the ovary can undergo metaplasia. So what is metaplasia? Metaplasia is differentiation of one type of epithelium to another type of epithelium. And classical example is endometriosis. That means the cells in the ovaries can have undergone metaplasia to the cells which are similar to the endometrium, and they are called endometriosis, or if there's a cyst formation, they are called endometriomas. Then the neoplastic, those are cells, these are actual tumors. Neoplastics are either benign or malignant. Either benign or malignant. So there are four categories of cyst: functional, inflammatory, metaplastic, and neoplastic. So what are the difference between benign and malignant ovarian tumors? Age. Malignant ovarian tumors are common in early childhood. If you get a ovarian cancer in the childhood. Those are called germ cell tumors. We'll be doing that later. And then older women. They are common in older women. You suspect if there's a rapid growth of the ovaries. Ovaries are pelvic structures. When they are grown, they can be palpated in the abdominal cavity. So if they are rapidly growing, then majority of the ovarian cancers are bilateral, 75% are bilateral. So if you have a unilateral cyst, is most commonly a benign cyst. There is a bilateral cyst, most commonly a malignant cyst. Then the consistency. Malignancies will have have now generally ovarian cyst. Inside the cyst, there are cyst contents. If it is fluid only, is mostly benign. If the contents are cystic and solid both, cystic and solid both, then it's more in favor of a malignancy. Then the vascularity. Vascularity of the ovaries can be checked by ultrasound scan, which we call Doppler ultrasound scan. If there's high vascularity, is in favor of a malignancy. Then malignant tumors are rapidly spreading. You have done in pathology, no? Rapidly spreading, and they can be adhered to the surrounding structures. So if the tumor is fixed, not mobile on palpation, it's most commonly a malignancy. So these are the features which differentiate between benign and malignancy. So some other thing, then malignant, if there's an ovarian malignancy, it can obstruct the venous return from the legs. It can obstruct the lymphatic drainage from the legs. So the leg, there will be bilateral edema, sacral edema, the peripheral edema, and that ovarian tumor plus bilateral sacral edema or ankle edema does indicate that is a malignancy. And of course, the lastly, the metastasis is in the spread of the cancer from the ovary to the liver, from the ovary to the lung, from the ovary to the brain. So all distant metastasis. So if there is any metastasis with the primary tumor in the ovary, it's mostly malignant tumors. Now we are coming to the functional cyst. I told you about this functional cyst earlier. Out of the four broad categories, first one is functional cyst. So the functional cyst arises during the normal function of the ovary under the influence of the pituitary hormones. So remember, because of the follicular stimulating hormone secreted by the anterior pituitary, there are many follicles being formed. We are learning physiology, this one. Many cohort of follicles are being formed. And then functional cysts, characteristically, they are unilateral. Unilateral in the sense it's present in one ovary, because only one side you get the ovulation. One dominant follicle is formed either in the left or the right ovary. So those are unilateral. And there is no solid areas in the cyst. And there is no ascites, no free fluid in the abdominal cavity. The functional cysts are generally small. There are maybe 3 to 5 centimeters generally. They are very rarely, it is more than 5 centimeters. Right. Commonly, they don't cause any symptoms. Now, you may have developed a functional cyst, but there are no symptoms. But however, they can be caught by accidentally. If you go for abdomen, some other problem, gastritis, and you undergo a scan, and somebody might find there's a cyst in your ovary which is 3 centimeters. So they are incidentally fine because there are no symptoms. Majority of the characteristics of functional cyst is majority, they regress on their own without any treatment. Spontaneous regression. So if you see a 3 centimeter functional cyst in a patient, safely you can say, don't worry, this will regress. I'm sure this will regress. We will do a repeat scan in 3 months' time. And majority of these cysts, they regressed on their own. Symptoms, if at all, majority I said asymptomatic. Very few people, a minority will have a little discomfort or dull ache, but they ignore that. If you have a little discomfort in the abdomen, you just ignore it. But however,
They can be symptomatic if it undergo a thing called cyst accidents. Cyst accidents. Cyst accidents are torsion, hemorrhage, and rupture. If there's a cyst get torsion, they present with acute abdominal pain. If there's hemorrhage into the cyst, then it will produce with acute abdominal pain. Then the rupture causes acute severe abdominal pain. If there are cyst accidents only, then it becomes symptomatic. So they rarely enlarges, and majority of them does not cause any irregularity in the periods. Periods are very regular. So therefore, there are no, if the patient is asymptomatic, it's been not being diagnosed. If the patients undergo scan for some other reason only, it's incidentally diagnosed, otherwise they regress on their own and disappear. Then cyst becomes the symptomatic. This happens if there's torsion, hemorrhage, or rupture. Diagnosis, in case if you have, now if it's a married person, we can do a clinical examination, bimanual examination. And then these are very small, 3 centimeters, 4 centimeters, 5 centimeters. As I said, they are mobile, they are benign cysts. Benign cysts are not adherent to other structure, they are mobile. And then ultrasound scan, if you do, the contents are mainly cystic. There are no solid areas. And then classical example of such functional cysts you see in multiple functional cysts seen in polycystic ovarian syndrome. I don't know whether you have heard about this terminology, polycystic ovarian syndrome. They have multiple cysts scattered. Management, I told you about the management. If they are less than 5 centimeters and asymptomatic, then follow up. But you want to treat them. They will regress on their own. And then sometimes if there's any pain, just give painkillers, Panadol, very mild analgesics is enough. But however, in rare circumstances, I'm repeating again, in rare circumstances, if it happens to be enlarged 7, 8 centimeters, then they might need surgery. Surgery by a laparoscope, or depending on the size. And what you perform is a cystectomy. You don't remove the ovary, which we call the oophorectomy. We remove the cyst only, which we call the cystectomy. So there are many types of functional cyst. Just remember these things. Follicular cyst, corpus luteum cyst, theca luteal cyst, polycystic ovarian syndrome. Follicular cysts are cysts which are formed in the first half of the cycle during the follicular phase or the proliferative phase. Corpus luteum cysts are called corpus luteum cysts when they are produced in the second half of the cycle. You know what is corpus luteum, no? When you ovulate, the dominant follicle becomes a structure called corpus luteum. And they corpus luteum, so when just before the periods, they regress. But in some people, it doesn't regress and form a cyst, and which we call the corpus luteal cyst. Then theca luteal cyst, just remember, and the polycystic ovarian syndrome. These are types of functional ovarian cyst. Then the neoplasm. I told you this for a second slide. Can you remember that? Yeah, 4 broad categories. Last one is the neoplastic. Now, this is what we are going to discuss now. Yeah. 3 main groups: epithelial ovarian neoplasm, stromal ovarian neoplasm, germ cell tumors. Epithelial ovarian neoplasms are the neoplasms which develop from the surface epithelium of the ovary, on the surface of the ovary. Stromal group is developed from the stromal cells inside this ovary. Then the germ cell tumors are tumors which originate from a special cell called the germ cell tumors. Germ cell tumors. So can anybody say what are germ cell tumors? Hello? Can anybody say what are germ cell tumors? Germ cells are what? Anybody in your physiology you have done it? In your anatomy, you have done it. What are germ cells in the ovary?
They are the haploid cells in the bodies.
What haploid cells? No, they are the primitive cells. So they are being formed in the embryo before the development of the ectoderm, mesoderm, and endoderm. So they are primitive before development of the endoderm, ectoderm, and mesoderm. They are called the primitive cells that's present in the embryo. And sometimes these cells can be trapped in the ovaries to the adult life. And the tumors originate from the trapped germ cell tumors. So epithelial ovarian tumors. Now this is first one is epithelial. So I'm going to discuss. Epithelial ovarian tumors are five types. Serous cyst adenoma, mucinous cyst adenoma, endometrioid tumors, fibroma, Brenner tumors. If you go through the classification of ovarian tumor in your 10 teachers, you will find this. Epithelial ovarian tumors are 5 types. Okay, serous cyst adenomas, mucinous cyst adenomas, endometrioid tumor, fibroma, Brenner tumor. So remember these things. Very easy. Then the germ cell tumors. I told you germ cell tumors, they are primitive cells. They are present from the embryonic age, before the development of the ectoderm, mesoderm, and endoderm. Common in infant and children, obviously. They are common in children, teenage girls, between the first decade or the second decade of life. First 10 years or second 10 years of life. Right. And then germ cell tumors can be again, they are the large group of ovarian. If you get a young girl, 15 years old girl with an ovarian tumor, mostly it's a germ cell tumor. Mostly it's a germ cell tumor. Yeah, hello. Yeah. Then hold on. Normal again, yeah. So germ cell tumors. Now, germ cell tumors also can be benign or malignant. Benign or malignant. So I told you, if a young girl gets a germ cell ovarian tumor, 18, 19, 20 years, 10, 11, 12, 13, 14 years, is mostly benign germ cell tumor. The commonest ovarian tumor in young girl is a type of a germ cell tumor, which we call teratoma. You have done in pathology, mature cystic teratoma, or in brackets, they are called dermoid cyst. So dermoid cysts are teratomas, and it contains tissues from all 3 layers of epithelium, ectodermal structures, hair follicles, sweat glands, skin. Those are ectodermal structures in the body. So this tumor, if you cut open the tumor, they will contain then these substances: teeth, bone, cartilage, then the endodermal structures, bowels, thyroid gland, mesodermal structures, brain matter. So these are basically tumors which have all 3 layers of mesodermal, ectodermal, endodermal structures. They are called benign. The commonest is cystic teratoma or dermoid cyst. I told you occurs from pluripotent germ cells, primitive germ cells before sexual differentiation occur in the embryo. Classically, they produce tumor markers. Tumor markers are protein substances produced by the ovarian tumor. They are called alpha-fetoprotein, and from the yolk sac. Now, germ cell tumors has the yolk sac. They are primitive cells. And beta HCG from the syncytium of the trophoblast. So they are still Trophoblastic tissue. Trophoblastic tissues are the tissues which you see in the embryonic development. Benign teratoma, second in the second or the third decade of life, derived from 3 germ cell layers. I told you this. There are thick materials inside on imaging. Sebum, hair follicles, teeth, cartilage, nervous tissue, thyroid gland tissue can be found. So, medicine is great fun. Medicine is great fun. Gian mata de gian mata de hello එකෙන් මට එන්න වෙන්න මේ ඒක නිසා මේ හෙටම යුනිවර්සිටි එකේ නැත්නම් මේ සන්ඩේ ඉන්න මේ සැටර්ඩේ ඉන්න මේ නව ලෝකෙට නව ලෝකෙ 10යි 10ට 11ට මාර්ක් එක දෙන්න ඕකේ නෑ සැටර්ඩේ ඉතින් ආන්න මගේ උදේ 11 මාර්ක් එන්න නව ලෝකෙ okay. So they are common in the first to third decade. Sorry, benign. Okay, I told this. Then the malignant germ cell tumor. They are common in the young age group. That's malignant germ cell tumor called the dysgerminoma. So you will remember, you will study this in pathology, dysgerminoma. That's the commonest. Teratomas are the benign tumors, they are the commonest, or dermoid cyst. So developed from, I told you, dysgerminomas are the counterpart of malignancies in the adult male, seminomas. Can you remember seminomas in the male counterpart? Dysgerminoma is the female counterpart. They are developed from abnormal gonads. They secrete LDH, lactate dehydrogenase. That's a tumor marker. And these are they are rubbery present, and they are very radiosensitive. Radiotherapy. If it is malignancy, you can treat them after surgery. If you give radiotherapy, it's very sensitive, and also it's sensitive for chemotherapy as well. So choriocarcinoma is another germ cell tumor, malignant germ cell tumor. Now we told dysgerminoma, now we are talking about choriocarcinoma. And these are the tumor marker here is dysgerminoma LDH, here beta HCG, human chorionic gonadotrophies. Okay, so you can read this one. So there's another malignant germ cell tumor called embryonal tumors. They produce both alpha fetoprotein and beta HCG. Then there's another malignant germ cell tumor called endodermal sinus tumor. Again, produce mainly alpha fetoprotein. So you can see different types of malignant germ cell tumor. Dysgerminoma, malignant teratomas, embryonal carcinoma, and endodermal sinus tumor. So these are malignant germ cell tumor, common in the young age group. Teratoma here, these are teratomas. Then other types are struma ovarian or carcinoid tumor. And these are, they produced what histamines. And they can produce diarrhea, tachycardia. So teratomas and struma ovarian. Then there's another called the sex cord stromal tumors. Sex cord. These are now I told you. I'm going back again. Yeah. Epithelial ovarian tumors. These are stromal ovarian tumors now I'm talking about. Stomach is inside the stroma. The stromal ovarian tumor, so they produce sex hormones, feminizing hormone, especially produced by granulosa cell tumors or theca cell tumors. They produce estrogen. And then masculinizing tumors, they are called Sertoli cell tumors or androblastomas. So they occur. These are not germ cell tumors, but they are called the sex-cord stromal tumors, which produce sex hormones. Then there are other category called borderline tumors. They are not benign, they are not malignant in between. So they have low malignant potential. So borderline tumors. So these are the characteristics of the borderline tumors. Then the ovarian malignancy. Ovarian malignancy I'm talking about now. I spoke about the germ cell tumor malignancies in the young girls. Now I'm talking about epithelial ovarian cancer coming from the surface epithelium. This is especially in the older women after menopause. So the peak incidence is 7 to 8 decades. They are very old people and they are common in certain individuals. These are high risk factors. High risk factors are nulliparity. They don't have children. They are infertile. They don't have children. I told you, sometimes some people have a family history. The family history, the gene being carried on BRCA1 and BRCA2 genes. You have heard about these abnormal genes in genetics when you are doing the second year. BRCA1 and BRCA2 genes. And then the oral contraceptive pill affords an protection against ovarian cancer. This is one drug which have been proven protective against development of ovarian cancers. So ovarian cancer, epithelial ovarian cancer, yeah, and then these are the different varieties. There are serous tumors, mucinous tumors. I told you about epithelial, endometrioid tumors, brain tumors, and clear cell cancer. Okay. And then how do they present? Majority of them, because ovary is a very, very friendly organ. Very friendly organ. It doesn't produce much symptoms. So in ovarian cancer also it produces less symptoms. Less symptoms. And then their presentation, they are asymptomatic. Early presentation, and then they can present sometimes with abdominal pain, pelvic pressure, dyspepsia, constipation. I told you on examination, these are because breast, remember, breast and the ovaries are like first cousins. First cousins. Now, when you see BRCA1 gene, what are the cancers which can happen with mutated BRCA1 gene? Breast, ovary, colon, and endometrium. Breast, ovary, colon, and endometrium. BRCA2 means breast and the ovary alone. Breast and ovary. So you can see breast. If somebody's mother has a breast cancer, the daughter might suffer from ovarian cancer. Breast and the ovary are very closely genetically related. They are like first cousins. So always when you have a patient with ovarian cancer, you need to examine the breast as well. So these are the examination. I don't think you have done these things. So the tumor. So all cancers has to be staged before treatment. I have told you this, I think, somewhere. Endometrial cancers, we did staging of cancers. Staging of cancers is basically you stage is a dissemination of cancers. How much it has disseminated to the rest of the body from the organ of origin. Organ of origin. Organ of origin is the ovary. From the ovary, how far it has gone. Right. So that is staging. We use the FIGO staging. That's a international staging system. All countries in the world, they adhere to the FIGO staging. Right. So we will be discussing these things as you go on, especially when you come to the final appointments. But basically, ovary is a very when you the classification of ovarian tumor is one full page in the 10 teachers. This tiny organ gives rise to varieties of cell types. If you read classification of liver tumors is half a page. Classification of ovarian tumors is one page. Ovarian tumor classification, generally, when we were medical students, we write it down on a paper and we paste it on the wall above your table. And we paste it. Whenever you sit for some study, you look at it. And then while constantly looking at it only, you remember it. Otherwise, it's very difficult to remember. So FIGO classification, FIGO staging system is all pasted on the wall over your table. Otherwise, very difficult to remember. So now knowledge objective which you have learned today, right? Functional skills which are physiological. Describe the clinical presentation. Discuss the management of functional cyst. Learn benign, borderline, and malignant ovarian tumor. Discuss the different categories, their presentation and management. Self-assessment questions. Discuss the management of an adnexal lump in a 40 years old patient. Adnexal lump, what is adnexal? I told you this is a combined word to combine both ovarian and the fallopian tube. Now this lady has an adnexal lump. We say left adnexal lump, she's 40 years old. So what are the adnexal lump which can happen in the ovary? Is it inflammatory adnexal lump? Is it a functional adnexal lump? Is it a metastatic endometriosis adnexal lump? Is it a neoplastic, either benign or malignant adnexal lump? Then 30 years old school teacher present with a pelvic mass, which is the size of a 20 weeks pregnant uterus in the level of the umbilicus now. She's concerned that she has malignant ovarian tumor. Describe how would you confirm or reassure her concern. So we have learned features of malignant ovarian tumor and features of benign tumor. So if you do ultrasound scan, malignant ovarian tumors will have solid areas, benign ovarian tumors will have cystic areas. If you do ultrasound scan, malignant ovarian tumors, there's high blood flow, benign ovarian tumors, low blood flow. So likewise, how do you reassure her concerns? She's thinking that she has got a malignancy. And discuss the management of malignant ovarian tumors. So these are the types of questions we might ask from you from the exam. So this is how you have to think now. When you study a topic, sometimes when you are listening for the first time, you'll be very confused. What's happening now? What's happening? What is he talking about? He's talking so much of theory. No. So these are the things which you need to learn. Self-assessment question, knowledge objectives. So the knowledge, if you learn the knowledge objective which I have categorized, you have mastered the ovarian tumors. You have mastered it so well. And then if you can answer some of these questions I told you with my lectures, then you have mastered that. All right. Any question you have? I always give lectures for you to think. I don't give lectures for you to learn. Learning, if you open a textbook, you can read and learn. There's no point. If I do the same lecture, learning exercises, there's no point for you. You have been learning from your A-levels now. You have been reading and learning. So it's no point. So medicine is a clinical subject, clinical. So you need to think now. What you have learned, you have to apply to a clinical practice. Clinical practice. Any questions you have? Hello.
Did you learn few things? Did you understand at least 10% of my lecture? 10%? Hello?
Yes, sir.
Yes, sir. Very good.
Yes, sir.
Yes, sir. No, sir. තමයි ඉතින්. හැමදාම. ඕම තමයි ඉතින්. Half of the batch is missing generally, or more than half. 120 students are missing. I don't know what they are doing for their exam. Because what we give lectures are lectures of clinical orientation. We don't give like much lectures on here for you to memorize. So it's very essential that you listen to lecturers because their lectures are very clinical oriented. Then only you can get distinctions. Because in the final year exam, there is a clinical component. There's a viva, there are OSCEs, there are clinicals. The theory part is very small amount. So now you have to be clinically oriented.
Sir, there is a question in the chat, sir.
Yeah.
Sir, shall I read it?
Yes.
Sir, is
Yes.
oophorectomy indicated for both benign and malignant tumors? Is there a place for biopsy?
Malignant tumors, oophorectomy, benign tumors is generally we do cystectomies because you remove the cyst only, leaving the ovarian tissue behind. Benign tumors, cystectomy. So that is to preserve the ovarian function. Malignancies, there is no way that you can prevent ovarian function, preserve. You have to remove the ovaries. So the malignant tumors, oophorectomy is mandatory. Benign tumors, oophorectomy is a treatment of choice. Cystectomy is a treatment of choice. Malignancy, oophorectomy is a treatment of choice. Benign tumors, cystectomy is a treatment of. It might vary as it. Now, for example, if you have a large benign tumor, big tumor, ovarian tumor in a 48 years old lady. So now she's going to have menopause in another 1 or 2 years time. So if you leave the ovary, it might become cancerous because cancers are common after menopause. So you might decide on oophorectomy. So, but general speaking, oophorectomy is not indicated for a benign tumor, and apart from exceptional situation which I just spoke about. But malignancy, oophorectomy is mandatory and the treatment of choice. Do you understand now? Hello? Hello?
Yes, sir. Yes,
Yeah.
sir.
Good. මෙහෙම තමයි හිතන්න ඕනේ. You have to think this way. Your brain has to work now. Don't let your brain to sleep. Sleeping. So you have to have, don't have dull brain. Always be alert. Thinking all the time. Medical students are thinking 24 hours a day. They are always thinking about what is happening. Otherwise, medicine cannot be practiced. Okay, any other questions before we wind up? Hope you understood well. Hello? Hello?
Yes, sir.
Very good. When I say yes, I'm very happy. Extremely happy. Okay, brother. Then we'll see you. Wish you all the best.
Thank you, sir. Okay, can you hear me?
Yes, sir.
Right, okay. Can you see the screen? No.
No, sir, we can only see the Zoom screen, not the presentation slides.